Good morning to every one of you. My name is Pam Hines, and I'm the Director of Nursing Research and Quality Outcomes here at Children's National Health System. And you are part of the third annual celebration of nursing research and quality outcomes. I'm welcoming you on behalf of Linda Talley, who is not able to be with us today. She's had a death in her family, but she sends her special greetings to every one of you. This is a week that Children's National, led by Dr. Mark Badshaw, creates in order for us to honor everyone here who poses questions, pursues those questions, takes the facts and the findings right back to patient care. This week is a celebration of that. How we generate those facts and principles most definitely comes from research and quality improvement science. Most of that is directed towards giving better care to children and their families, but some of that research and quality improvement effort is also directed towards each other so that we can support each other in the daily efforts of making the care of children and their families better. We will always be working together to make care better. So like all forms of research and nursing quality is creative work that we really want to take to a logical end. And all forms of creative work are led then by a most creative person. And today, for a moment, would you join me in celebrating the creative person who took the lead for this entire day for two reasons: for her excellence in leadership and because it's her birthday, Eileen Eng. And Eileen has led quite a group of us who are really all passionate about nursing research and quality. And would the members of the planning committee please stand so that all of our guests who are on webinar and who are in the room will know to whom to go should they have any questions. Although today is labeled nursing research and nursing quality, what every nurse would always say is that what we do as one discipline is because of all disciplines. And so today we celebrate all disciplines, their research, and their quality improvement efforts. To all of us, I thank you for the way that you ask questions and take all your findings right back to the point of care. So this morning, we're going to start our day with a remarkable person, Dr. Ann O'Mara, who has been a colleague of mine and of Children's National for many years. I'd like to tell you just a little bit about her, and if we have time, of course, fun stories. I may have to tell you those individually and not on a PA system. But what I would like you to know about Dr. Ann O'Mara before she offers us the keynote is that she is the head of palliative research at the National Cancer Institute at the NIH campus and in the NCI Division of Cancer Prevention. This means that she manages a portfolio of individual research studies and the Children's Oncology Group collaborative portfolio of studies across the entire nation. So a part of her portfolio of research is about treatment-related symptoms, symptoms that absolutely bring cancer patients to their knees and their families with them, symptoms such as pain, fatigue, depression, anxiety, neuropathy, and more. And in addition, part of her portfolio would be clinical trials, research grants related to palliative and end-of-life care. What I would like you to know about Dr. O'Mara as well is that she is a part of multiple trans-institute initiatives across NIH. And there's a particular reason for that, and that is because Dr. O'Mara is known for being very collaborative, of good humor, of good memory, and really believing in the contributions of others. In addition, she's very forthcoming with ideas and possibilities. She is known as a person who looks at possibilities. Before she joined NIH, she was on faculty and actually taught advanced practice nurses and was quite known for her supportive ways of bringing out the best in her students. In addition, she has been a PI for research in oncology and particularly looking at how to support physicians and nurses who practice in that specialty. What I would also like you to know is that she is nationally renowned in her own work and has received multiple national awards, including from the American Pain Society and the Oncology Nursing Society. Quite renowned. This year, she also represented the NIH perspective on replication in science as part of the Conway Chair monthly conversations. She was stunning in the clarity of her viewpoint that was shared during that conversation. Please would you welcome Dr. Ann O'Mara as our keynoter for the 3rd annual.
Thank you, Pam. I'm very humbled. I have to make some disclosures and some confessions. So my first confession is that I have never taken care of a child. As a nurse, I did a nursing school, but after that, it's always been in the adult setting. And when I came to NCI and was assigned the Children's Oncology Group, my anxiety went off the wall because I thought, what can I bring to these people? What can I bring to these experts in the Children's Oncology Group? And that was my encounter with Pam Hines, who led the way in helping me learn from the Children's Oncology Group. And as I was saying to one of my colleagues here, I've learned so much from the Children's Oncology Group in terms of what we could bring to the adult setting, of how collaborative it is within the oncology setting for children. My other sort of caveat is, as Pam said, we work in multiple disciplines. So what I'm going to present to you is really very multidisciplinary work. Is it nursing research? I don't know. I'm not sure. I'm going to present to you some nursing scientists, but some other scientists as well. So with that being said, this is what I'm going to do today for the next 45 minutes or so. I'm going to compare and contrast the art and science of clinical care in the context of symptom management. I'm going to define passion, and I want to stop right here because I really have to give Eileen Eng a lot of kudos for sitting on the phone with me and helping me think through what I wanted to present to you. Usually as a program director, I'm asked to come and talk about how to get some money from NIH. And I knew that this is not what the audience wanted to hear. And through Eileen's just exquisite questioning of me, she helped me come up with the title and how I was going to go about doing this. So I'm going to define passion. I'm going to highlight some key achievements from 2 passionate leaders that I consider passionate leaders in the field of symptom management. And I'm also going to describe their accomplishments and how their achievements have led to sort of where my portfolio of symptom management is right now. So let's start with the art of symptom management. What you see up here are 3 pictures that should bring forth some words from you as you look at these. One of them is empathy. The other is caring. Those are the 2 that strike me. The other, on all 3 of these, is about relationships. The relationships that we as clinicians establish with patients and their families. And it's an art. It really is an art. Some of us are very good at it. Some of us are good at it, but not very good at it, but we all try. But there's also a science to the art of symptom management, and that is our exploration of how we communicate with patients and how to better communicate with patients, thereby improving our relationships with our patients and hopefully improving our empathy and being as empathetic as possible. So while it's an art, there's also a science to it. Then there's the science of symptom management. And in these 4 pictures, we see a lot of biology. We see some physiology. We see some maybe biochemistry as we look at these 4 pictures. But the overarching sort of theme about this is about data collection. When we think about the science, we think about data collection, how we collect it, how we analyze it, and how it informs what we go forward doing. So that's the art and science of symptom management. That's how I look at it. I think that's how my colleagues look at it. So now let's talk about passion. So Webster defines it as a strong feeling of enthusiasm or excitement for something or about doing something. So I'm going to pause right now, and we're going to look at a film clip. It's a film clip from Terms of Endearment. Some of you are a little bit older, so you probably may have seen it. It was in 1983. And the basic background to it is Shirley MacLaine plays the mother of an adult child who has been diagnosed with terminal cancer. And in this next film clip, I hope this works. How about that?
It is after 10. Give my daughter the pain shot, please.
Mrs. Greenway, I was going to.
Oh, good. Go ahead. It's just a few minutes. Well, please, it's after 10. It's after 10. I don't see why she has to have this pain.
Ma'am, it's not my patient.
It's time for her shot. You understand? Do something. All she has to do is hold out until 10. And it's past 10. It's 10. My daughter is in pain. Give her the shot. You understand?
I'm going to behave.
Give my daughter the shot. Thank you very much. Thank you.
I mean, I could do this. Escape, get there, and then I go, I was pretty good. Escape again. So she gets me to that. So that's an example of passion. And when I saw that, when I first saw that, I said, that's what I want to be. That's what I want to embody in the students that I teach, is to get everybody's attention. Now, Shirley MacLaine, as the mother, did it in terms of her love for her daughter and wanting something. And I think that we can take that same passion in our profession and in our scientific endeavors and do the same thing. So I found this clip, or I found this little image, and it really embodies what I think about pain and about patients who experience cancer pain. Its no kind of sensation is keener and more active than that of pain. Its impressions are unmistakable. And they are really unmistakable, as Shirley explained to us, when it's unrelieved. And so what I'm going to do for the rest of this session is really talk about cancer pain. And I'm going to take you on a journey about cancer pain, because that's really my passion, is cancer pain. How I got to be passionate about it, I don't know. It struck me. So, and I also want you to keep in the back of your mind 1983, because that's the journey I'm going to take you on, is from 1983 to now. And I'm going to introduce you to two leaders in the field of cancer pain. On your left is Chris Mizakowski. Chris Mizakowski is a nurse scientist at the University of California, San Francisco, in the Department of Physiological Nursing. And I called her up and I told her what I was doing. And I said, I want to get your sense of passion, Chris. What got you into this field? And what got her into the field is pretty much what Shirley explained or showed us on the film. Her father died of intractable pain from laryngeal cancer. And she told me her story, and it was quite profound. And she said when that happened, she said, and this was in the late 70s when her dad died, she said it inspired me to move on and to go on and really look at how we can relieve patients suffering from cancer pain. The individual on the right is Charlie Cleland. Charlie Cleland is at MD Anderson. He's a behavioral scientist. He's a psychologist. And he has been at MD Anderson probably for about the last 15 years. He started in cancer pain, and I will tell you his story as well. And his story is a little bit different. It's not so much personal as some observations he made before he got into the field of cancer pain. So these are the two individuals I'm going to take you on a journey with. So I'm going to start with Chris. So some of Chris's early discoveries. She started in the field of oral mucositis, and in her early work, late 1990s, she used in a series of clinical trials, she used several different agents to try to ameliorate both the signs, the redness that we see with mucositis, as well as the symptoms, the pain that patients experience from oral mucositis. And what she found is that salt and soda were equal to chlorhexidine or sucralfate or magic mouthwash. And that was published in 2000. And I would say that probably 16 years later, you go to a number of different hospitals and we're still using chlorhexidine, we're probably still using sucralfate, and we're probably still using magic mouthwash. The other thing that she also discovered in a series of about 70 patients, outpatients, is she discovered that patients were not very good, cancer patients were not very good at adhering to analgesic medications. She found out that one of them was the side effects, that really the side effect of constipation, of tiredness, of fatigue, led them to not want to take their medications. So as a consequence, they were in a lot of pain. The third discovery that she made was that in her review of the literature back in the mid-90s, most research was done in cancer pain of hospitalized cancer patients. Yet in this third bullet, what she saw and what we knew back in the 90s was that 80% of cancer patients are treated in the outpatient setting. So what we're seeing in inpatient is very different than what we're seeing in the outpatient. So this led her to do a randomized study of pro-self pain control program versus usual care. And this was her first R01 funded by the National Cancer Institute. And in that clinical trial, she recruited 212 oncology outpatients reporting pain from bone metastases. So these were all patients with advanced cancer with metastases to the bone. Her intervention consisted of a very intensive, individualized education regarding pain, the side effects of pain, how to manage those using weekly pill boxes, and how to talk to physicians on reporting their pain. One of the things that she discovered in some of her early qualitative work was that patients, and probably many of you have heard this, patients do not like to report cancer pain to their physicians. The examples that they give, or the reasons that they give, is they don't want to bother the patient. They are afraid that if they report their pain, they may not get their chemotherapy. If they are on a clinical trial for their cancer, they may be taken off their clinical trial. So patients are reluctant to talk about reporting their pain. And so in her scripting that she worked with patients and their family caregivers, she taught them how to call and get better medications for their patients. So that was week one, and then after this intensive individualized education that advanced practice nurses gave to the patients, she then had follow-up at 2, 4, and 5 weeks, asking them how they were managing their pain, what kind of medications they were on, et cetera. The results were published in the Journal of Clinical Oncology, probably the lead journal in the discipline of medical oncology. It was published in 2004. And in this, she noted that there was a significant decrease in the least, average, and worst pain in the intervention arm. So the intervention arm was really a winner. It was a winner. It was patients reported less pain after this intervention. Some interesting observations that she made, though, prior to the start. At the start of the trial, less than 30% of the patients had appropriate, and how she defined appropriate was around-the-clock medication, analgesic medications, less than 30%. At the completion in the intervention arm, that rose to 37%, and in the standard arm, 32%. So there was an improvement. Still, there was 63% were not receiving appropriate medication. The third bullet, or the third item, I think is very interesting. Approximately 50% in both groups had NSAIDs prescribed at the start of study. And back in the early 2000s, NSAIDs were considered very, very important in the managing of pain. And even today, it is considered very, very important because we do believe that there is a significant inflammatory process that goes on in cancer pain. but only 50% were receiving NSAIDs, which was a standard part of the WHO guidelines for pain management. So this gives you a sense of sort of the landscape of pain management in the early 2000s, not so long ago. So one of her other discoveries was that in addition to there's no kind of sensation is keener and more active than that of pain, its impressions and unmistakable, but it rarely occurs in isolation. Rarely do we find a patient with cancer saying, I only have pain. There's always other symptoms. So at about this time in the early 2000s, the NIH convened what we call a state of the science in the area of pain, depression, and fatigue in patients with cancer. And Chris was one of the keynote speakers at this conference. And at the end of the conference, there was a number of publications. And Chris specifically wrote on symptom clusters, what we call co-occurring symptoms. And she had written in 2002, it was published in the Journal of JNCI. The meeting occurred in 2002. This was published in 2004. She believed that this was the new frontier for symptom management, and it was looking at co-occurring symptoms or symptom clusters. And as I said in my previous slide, patients rarely present with a single symptom. And she identified 5 areas that she and her colleagues believed were very, very important in moving the field of symptom management forward. That we needed to put more focus on multiple co-occurring symptoms. We need to determine the nature of the clinically significant clusters of symptoms and the associated prevalence rates. So how do they come together? When patients report symptoms, how do they come together and what is that prevalence? What is that severity? We need to look at the relationships among symptoms. Which one is occurring first? Which one occurs later? Sleep and pain are often, very often, unrelieved pain often occurs simultaneously with sleep. She believed that we need to come up with some cut points for symptom severity. When is it starting to interfere with patients' functioning? And then finally, elucidating the mechanisms underlying development of these symptom clusters. In other words, is the biology, are the mechanisms the same for what we see in, say, cancer pain and what we see in the sleep disturbances that occur simultaneously? So now we're going to switch and we're going to talk a little bit about Charlie. I'm going to talk a little bit about Charlie Cleveland's work. Charlie started out not in cancer pain, but in patients with chronic pain. So this was back in the late 70s, early 80s. He was working at the University of Wisconsin, and he was working with patients with chronic back pain, chronic headaches, with a lot of issues, he told me, regarding substance abuse, a lot of substance abuse underlying a lot of the chronic pain. But one of the things that really struck him is he was recruited by Paul Carbone at the University of Wisconsin in the Cancer Center, and Paul said, I really want to have you move into the Cancer Center. He said, we anecdotally are seeing a lot of unrelieved pain amongst our cancer population. And he said one of the things as he started to meet cancer patients and talk to them, he saw that there was a huge dichotomy between patients with cancer reporting pain and patients with what we call benign pain, patients with chronic headache, chronic back pain, et cetera. And he said one of the things that struck him is that in the cancer population, it's looked upon, cancer pain is looked upon as a consequence of the disease. If we can cure the disease, then our pain will go away. So cancer pain became secondary. He said that really struck him. Versus the patient reporting benign pain, that was the predominant problem. We really had to get at that. Even though we knew it may have been in the back, that was the forefront, whereas the cancer, the disease, was the forefront. Another phenomenon that he really noticed a difference in is in our chronic pain population, our benign pain population, there's a phenomenon called pain catastrophizing. And in that phenomenon, patients, for lack of a better word, ruminate about their pain. They fear it will never go away. It encompasses their life. They become almost a prisoner to it. In the cancer pain population, Charlie told me, he said, I rarely saw it. He said patients were so driven to have their cancer managed and hopefully cured that he said, I knew they were reporting pain of 7 or 8. They were incapacitated by it, but they weren't catastrophizing about it. He said that really struck him, that there was really a significant difference. So that was his early work. In 1984, he reported on data from his first R01 from the National Cancer Institute, and it was the impact of pain on the patient with cancer. Now, this work was done at the University of Wisconsin, and he reported it in the journal Cancer. And the first bullet, which I thought was very interesting, was how to measure pain. Is it the patient or the clinician? And I just want to do a little caveat here that in 1968, Margot McCaffrey, a nurse educator and a pain expert, said and defined pain and said it's whatever the patient tells us it is. However they describe it, it's what the patient tells us. 16 years later, in 1984, they were still struggling on who should be reporting pain. Should it be the clinician or should it be the patient? So that was one of his opening remarks in the journal. He found in his work of 660 patients, both inpatient and outpatient at the University of Wisconsin, that 75% reported some level of pain for those who had metastases, whereas those without metastases, it was about a rate of 14%. For patients, he used a scale of 0 to 10, and for patients reporting a severity of 5 or higher, it disproportionately affected their activities of daily living. It had an impact on their activities of daily living. Back in the 80s, now remember 1984, Shirley MacLaine, 1983, opioids were the mainstay, but they were not widely employed, he found. That there were clinician barriers, there was a lack of knowledge, and there was a fear of addiction. There were patient barriers. There was poor adherence, as Chris found out, and that they did not want to bother the clinician, as Chris found out. So here are two individuals across the country coming to some very similar conclusions at about the same time. Chris's was a little bit later. So this work led Charlie to work with the Eastern Cooperative Oncology Group. It is one of our NCI-funded cooperative groups that are funded to develop clinical trials, national clinical trials for the treatment of cancer across the country. Many facilities affiliate with ECOG. There's several other cooperative groups, but we'll just talk about ECOG because that's where Charlie did his work. He recruited 1,300 outpatients with metastatic cancer from 54 different treatment locations across the country. He had two sources of data. He asked patients, and remember, this was a cross-sectional, so it was a one-time assessment, who rated their pain severity. They reported their pain-related and functional impairment, which really drew from the work that he did at Wisconsin. He asked about their degree of relief from the analgesics during the preceding week. So with a 1-week recall, what was your pain relief? At the same time, he also asked clinicians what they thought was attributed pain to various factors. He had a list of factors that he asked these clinicians, said, what do you think your patient's pain is from? He asked his clinicians to describe its treatment, and he asked them to estimate its impact on activities of daily living. So he's really asking the same questions of clinicians that he was asking of patients. He also developed what we call the Pain Management Index, and to this day it's still used. And how he calculated this is he used the WHO guidelines and they looked at each level of pain, and they said for this level of pain, this is how much pain medication a patient should have. So that was the ideal. That was, we'll call that our standard of care. He then did that, he developed that, and then based on the data that he got from clinicians and patients, he actually was able to determine whether they were actually receiving the appropriate medication. So findings from this study were reported in the New England Journal of Medicine. To this day, it is still considered a landmark study in the area of cancer pain. So amongst his 1,300 patients, over 50% reported pain. Of those, 62% reported functional impairments due to pain severity. What that means is that those patients primarily were reporting greater than a 5 on a 0 to 10 scale. 42% were under-medicated, and that was based on this pain management index, that they were not receiving the appropriate medications for their level of pain. Minority patients were 3 times more likely to be undertreated than non-minority patients. Among those 1,300 patients, the other things that he found was that there were certain predictors for patients. Gender, men were more likely to be adequately treated than women. Patients over 70 were less likely to be treated for their pain. Patients with a better performance status were less likely to receive adequate pain medication. And that there was greater discordance between the physician's and the patient's rating of pain severity. So in 1984, in the journal Cancer, he posed the first thing of who is the better reporter, clinicians or patients. And in 1994, in the journal, or in the New England Journal of Medicine, he found that, oh dear, it still is a discordance, with physicians reporting less severe pain and less impact on activities of daily living than the patients were reporting. So what you have before you is the initial listing of the MD Anderson symptom inventory. As a result of Charlie's work at ECOG and through these 1,300 patients, and what he discovered is that patients, as Chris did, report quite a few symptoms. So as a result of that work, he developed these 26 items. And through his work at MD Anderson, because he had already moved to MD Anderson, he reported, he found that patients, from his many scales that were out there in assessing patients, he came up with these 26 items. And he then interviewed a number of patients, both outpatient and inpatient at MD Anderson, and asked patients to complete these, this listing and in terms of severity. He also asked them to report on the interference of these symptoms in terms of their activities of daily living, their ability to get out of bed, their ability to walk, their ability to engage with their family members, and general quality of life. So it was not only severity, but it was also impact. And through some statistical, I'll call it mumbo jumbo because I'm not a statistician, he made some interesting discoveries. He found that certain symptoms came together immediately, and in fact, for many patients, they really were proxies for each other, except for nausea and vomiting. For example, patients often reported difficulty paying attention, distress. Here, let me use my thing, so it'll be better. So what patients often reported was that difficulty paying attention, distress, and worrying often came together. They reported them almost interchangeably. And that sadness and nervousness often came together, and particularly fatigue and weakness came together. In other words, they reported them almost interchangeably. But through his work in looking at their interference with activities of daily living, what he found is that as you moved further out, some of these came together. For example, nausea, vomiting, and as you come down, bleeding came together. So a lot of these came together. More interesting was lack of appetite and feeling sick. Although they were not proxies for each other, they co-occurred. When we get down to lack of appetite, inability to get things done came together with weakness and fatigue. So a lot of these came together further out and had an impact on their functioning. So let's look at this. Again, they came together, and what I want to point out here is that all of these seem to come together right in here. And then he came to find out that these green ones came together, and as you look at them, you see that a lot of this is our psychosocial issues that the patients have. Lack of appetite, which I thought was very interesting because I thought lack of appetite would come up here with your mouth sores, et cetera. But in his findings, he found that these came together, lack of appetite and feeling sick came together, and then lack of appetite came together down here with inability to get things done. And then finally, what he found is down here, pain and disturbed sleep came together way out here where more functional impact was being entered into his modeling that he was doing with his statistics. And then dry mouth and numbness and tingling, way, way out here, which, as Charlie said to me, because I said, how does this all come together? And he said, the thing is, we don't know so much the biology, but we think that there's some sort of neurological component here when patients have numbness and tingling and have the dry mouth. He says, we think that there's some sort of neurological biology going on here. One of the things that he was able to discover is that many of these items could be reduced. Clinicians, because he also interviewed clinicians about these items, and what clinicians said is, do not have nausea be a proxy for vomiting. They're two different phenomenons, and they must, while patients often they co-occur, they're not a proxy for each other. But what he did take out was fatigue and weakness. He used only fatigue. That these two often, patients said, they were a proxy for each other. So these 26 items, and one of his goals was to make this a more efficient scale. And he ended up with 13 items that to this day are still used in assessing patients, plus his 6 items of inability to function. So in summary, what did we learn from their work? That cancer pain is underreported and it's undertreated. That race, ethnicity, age, and gender all interfere with, are predictors for undertreatment. Pain rarely occurs in isolation. That there's other symptoms that patients report that underreport and are undertreated. And the clinician is not the best source for reporting prevalence, severity, and impact, and they may actually harbor some issues or biases about how to report this. So this was all in early 2000. 2 weeks ago in the Washington Post, there was an article. Why are Black patients undertreated for pain? They continue to be undertreated for pain. This was April 5th, 2016. This is a fascinating study. It was at the University of Virginia, and it was a survey that they gave medical students. And they asked medical students a number of items that were false about Black patients. And I wrote them all down because I still can't remember them. So here are some of the items that they were asked. Blacks' nerve endings are less sensitive than whites. Blacks age more slowly. Blood, when compared to whites, African Americans' blood coagulates more quickly. African Americans have smaller brains. They have a worse sense of hearing. They have thicker skin. They have a better sense of smell. They have less efficient respiratory system. They are more fertile. They are better at detecting movement, and they have a stronger immune system. All of these items were given to the medical students. 50% of the medical students endorsed at least one of those items. So this is an enlightened, educated group, and they endorsed one of those items. In the same article, they also looked at a series of patients coming through the emergency room and looked at pain management. And African Americans, when matched with a white person for the same condition, received less pain medication than a white person in today, 2016. So what we discovered in 1983, 23 years later, or 33 years later, still occurs. So where has this led us? I'd like to think of Chris and Charlie as this dog trying to lead us in different ways, and we need more of Chris and Charlie. That's what I would say. We need more of them. But what they've also taught us, this work has taught us, is that we have a lot of different directions that we can go in. There's a lot of different areas that we can go in. So one of the areas that our leaders have gone in is the area of chemotherapy-induced peripheral neuropathy. It is a dose-limiting toxicity in our patients. About 40% experience it in varying degrees. It is a symmetric, distal length-dependent, what we call glove and stocking sort of distribution. Starts in the feet, works its way up, starts in the tips of our fingers, works its way up. It's predominantly a sensory phenomenon rather than a motor phenomenon. It's usually most seen with oxaliplatin and some with the taxanes, but with oxaliplatin, it may continue to develop after the patient has finished treatment. And despite numerous small and moderately sized clinical trials testing a variety of agents, only duloxetine has been found to be moderately effective. This was published in the Journal of Clinical Oncology in 2014. And the purpose of it is that by that last bullet, there's been a lot of agents that have been tested. And what this article came out with is none of these work. None of these are recommended for the treatment of patients. And all of these have been treated. What the authors discovered, or what the authors reported on, was that most of these trials were very small. Some of them were not very well-designed trials. Some of them were open label. Blinding was an issue. There was a lot of issues with the clinical trials, but they could not recommend anything except duloxetine for oxaliplatin-induced peripheral neuropathy. So I would argue, and what our authors argued, is that we need more biology. This is the area that I think is the weakest in our symptom management portfolio, is we don't have enough biology. So what I want to take you on now is my current portfolio and the science that NCI is now supporting. And I'm going to do two. I'm going to do pain, because that's been sort of my theme throughout this. I'm also going to give you a taste of what we're doing with cognition. So what you have before are 5 investigators. And when we talk about biology, a lot of people think, oh, we're talking about animal models and mice, et cetera, et cetera. Well, interestingly, of these 5, there's really only 2 that are really looking at animal models and pain. Kobe Hygen is in Charlie Cleland's shop at MD Anderson, and she's doing some animal work for chemotherapy-induced peripheral neuropathy. And Pat Manti at the University of Arizona is doing some interesting, very interesting work on metastatic prostate-induced bone pain. The other 3 individuals are all doing work in humans to try to get a better sense of the biology. Eric Moulton is doing work in the pediatric setting on cancer pain. Of course, Chris's work is in peripheral neuropathy, and she is trying to get a better phenotype, what we call a better description of what patients are experiencing when they have chemotherapy-induced peripheral neuropathy. So that's the area of pain. So in cognition, another problem that patients have during treatment and when they are finished with treatment is neurocognitive problems. And here are 3 investigators supported by us. Peter Cole is doing some animal work in chemotherapy-induced cognitive deficits in the pediatric rat population. And Michelle Janelson at the University of Rochester is doing both clinical, preclinical, and clinical work in approaches to cognitive impairment, trying to take what she learns in her animal work and seeing how it plays out in the human condition. And then finally, Lisa Cahaley is looking at cognitive changes in the pediatric population of comparing the neurocognitive changes between proton and photon or surgery for treatment of brain tumors. So that's what we're supporting. So this is our portfolio. This is the portfolio that I manage that Pam talked about. So in the center is symptom science, but all around it are all the different areas that our investigators are looking at. Cardiotoxicity. We're interested in the pediatric issue of symptom management. We're looking at the psychosocial issues. We're looking at medication adherence. We think as we use more and more oral medications, we're thinking that the side effects from this are having an impact on patients being able to adhere to their medications, their oral medications for their cancer treatment. We're very interested in the adolescent and young adults because we think that their issues in dealing with cancer are very unique to their population, and yet it's a very understudied area. I have maybe 1 or 2 projects in my portfolio. So this is all the stuff that we support and really exemplifies what I call the passion of symptom management. So what are some other research gaps? I've told you my bias of biology. I think we need a lot more biology. But I have other biases. I think we still don't have, even though Chris told us back in 2004, we need a better sense of what the prevalence and severity is of the problem. I don't think we still have a good sense of how these symptoms come together and what their prevalence and severity is. I think it's very differential across populations. I think what our pediatric population experiences is very different than our young adults. I think even in the adult setting, I think our elderly have different symptoms, et cetera, given the same chemotherapy that our middle-aged adults experience. I think we have serious measurement problems in actually measuring and patient reports of the pain, its severity, its impact. I think our measures, is what I would say, are very crude. I don't think they're very precise. In the clinical trial setting, I think one of the major challenges we have, and the trial on duloxetine really taught us this, is there's super responders and there's non-responders. What is it, again, about the biology of that symptom or symptoms that, given all of the homogeneity of the population, leads to we still have patients that do not get relief from their pain? So those are just a few of the questions that still we face in the area of symptom management. So I'm going to end with Albert Einstein, and I think Charlie and Chris would say the same thing. I have no special talents, but it's really, I am only passionately curious, and that's what I learned. So I learned from my portfolio, both from Chris and from Charlie over the years of knowing them, but even my other investigators. It's about this passionate curiosity that they have to try to get answers to our questions. So I guess we have our panel now.
Dr. Omeros, thank you so much for your passion, facts, figures, and now we will move on to the panel. And may I please invite Dr. Peter Scheit, Dr. Mark Batshaw, Dr. Debbie LaFawn to the stage. I'm going to briefly introduce them while they are joining us, and then Dr. Omeros is actually going to be a moderator for the comments that are about to follow. So if I may tell you a little bit about Dr. Mark Batshaw, and he is a developmental behavioral pediatrician. He's also our Chief Physician Officer, Chief Academic Officer, Executive Vice President here at Children's National. He's also the director of the Rare Disease Clinical Research Center and the Urea Cycle Disorder Consortium. And oh my gosh, if you ever have a chance to look at his publications, there's some very exciting work about the longitudinal analysis of the urea cycle disorder. He is also the director of the Children's Research Institute here, and he is a professor at the George Washington School of Medicine. May I also introduce you to Dr. Debbie LaFawn, who is an advanced practice nurse for our PANDA team here and one of the founders of that team. She's also a member of the Pediatric Palliative and End-of-Life Research SIG and Clinical Care SIG, as well as on the faculty in the School of Nursing, School of Medicine at the George Washington University. I would like you to know that at the national level, she is the first chair of the Evidence-Based Practice and Research Committee for the Association of Pediatric Hematology Oncology Nursing. She's also the recipient of several national awards and one of the first in the nation to demonstrate the feasibility of implementing anticipatory palliative care in oncology for children. May I also introduce to you a wonderful colleague of mine, Dr. Peter C. Scheit, who here at Children's National is now the director of the Office for Grants Enhancements, which is a part of our CTSI-CN award and grant. He has made all the difference for all faculty here in a funding rate, and he can clearly speak to and point to an increase in funding up to 30% of our assistant member grants. That's unheard of across the nation. I want you to know a little bit about his background. He certainly hails from Duke University, part of his training at the University of Utah, also at Johns Hopkins University. And his training is both in medicine, of course, but also in public health. And when you follow the impact of his research, you will see the impact on child safety, and very exciting for me, the outcomes of breastfeeding on the mother and on the child, the cognitive development of the child. It's remarkable what he has done for the health of this nation. So we are actually going to respond sort of extemporaneously to comments from Dr. O'Mara, and she's going to try to moderate it. Can you imagine the challenge of moderating the four of us? Dr. O'Mara.
So I didn't know I was supposed to be a moderator, so like...
I'd like to be a commentator. We are flexible.
Well, I would like to open it up to questions that, and I guess we should start with our panel here, and maybe your questions will generate some questions from our audience.
Well, I can sort of start. First of all, thank you very much. It brought back a lot of memories for me. I was an intern starting in 1971, and at that time, the vast majority of children who had acute lymphoblastic leukemia died. In fact, 90% of them died, and of course now it's just the reverse of that. And when we talked about palliative care at that point, we were really talking about hospice care. We were really talking about how to care for these children who are dying. And now, of course, when we talk about palliative care, we're really talking about a much broader sort of issue for the children who have chronic diseases, be it cancer or other chronic diseases, and how to deal with all of the issues that Dr. O'Mara had been talking about, the pain, the effect on their daily living, and so that the way we conceptualize that, I think is very different than it used to be. And I think all of us, whether we work with children with cancer or with other chronic diseases, need to be aware of these sort of issues. And we now have a very strong palliative care team that's led by Debbie, and the hope is that you would take advantage of that. So that was one reflection that I had. The other was about the biology that you were speaking about, and I wanted you to be aware of at least two programs that we're involved in at Children's National, dealing with the biology of pain and its treatment. One of them is led by John Vandenanker, who is a neonatologist and a clinical pharmacologist. And he has been very interested in the issue of opioids in neonates and whether there's a difference. And Dr. O'Mara spoke about this with regard to racial differences in terms of how pain is managed. Well, what he's been looking at are the actual genetic differences between infants of different races and how they actually respond, how they metabolize opioids, and how that can affect what the proper dosage is for these children. So that's one aspect of biology. The other is done by Julie Finkel, who is one of our anesthesiologists, and who has developed a prototype called an algometer, which allows you to actually take a photograph of the pupil of the eye of a child who isn't actually able to tell you how much pain they have because either they're very young or they are not conscious enough to be able to do that, and to be able to, by using an algorithm, look at how much pain the child is actually experiencing and how effective the medication is in controlling that. And I think these are just two examples of what Dr. O'Mara was saying in terms of the necessity of our learning more about the biology of pain to be able to more effectively treat it. Debbie, maybe you want to say something more about the palliative care program here and where it's headed.
I can certainly talk about that, but I wanted to respond first to your comment about Dr. Finkel's research and relate that to sort of translation. About a year ago, we had a patient in the ICU, a bone marrow transplant patient, who the nurses noted was not responding as they would have predicted to pain medication, actually having a an almost opposite effect as you would expect. And we tried to rotate opioids and do all the things that we learned to do in our palliative care world. And one of our advanced practice nurses works with Dr. Finkel and actually used that technology to assess the patient and realized that she was actually having another syndrome related, and we were able then to effectively manage her pain. So here's taking what was at the bench and now translating into practice. I don't think we're ready to go, full force, but we're actually using this stuff right in practice, and I think that is so important. The palliative care team at Children's, I think, has really expanded over the last few years. We now have a funded program, much in part due to Dr. Batshaw's strong commitment and advocacy for us, as well as Dr. Hines. And we now see patients all over the hospital, inpatient and outpatient, still primarily an inpatient service, and have really expanded from a team of 2 to a team of now 3 physicians, 2 advanced practice nurses, a nurse case manager, and social worker, and then we use our other interdisciplinary colleagues as we need. So we really have expanded quite a bit. I wanted to also link that to Dr. O'Meara's comments about passion, because that's really how we started and how we continue to drive what we do. That's how my work started. Nurses at the bedside, Cheryl Reggio, who was here, just saying to me, we have to do this better. Patients and families are suffering in transplant. We don't know what to do. What can we do? And I had an aha moment and said, well, what about palliative care? And we started that in practice, and now it is a fully established standard of care in bone marrow transplant. And I do think that we have made a difference up there, and we are measuring some of that today. So passion, really, at the very basic level, the clinicians at the bedside, having the courage and the passion to speak up and say something's not right here, and then reaching out to, our science colleagues here can make such a difference in the care that we give patients.
And I was thinking back on what you discovered for adults in the 1970s and 1980s. We are looking at now with children. So with the question being, should it be the clinician reporting the pain and assessing the pain, or should it be the patient? And so we are very much in this audience about the child voice and trusting the child voice, and how can we make that voice so credible that that voice will be a partner in directing symptom treatment. And so you are, of course, the NCI program leader for the grant that Bryce Reeve and I have. We have an R01 letting us create a child voice matching parent voice indicator for treatment toxicity. Now, this is a set of toxicities that only clinicians have reported on for the last 4 decades. So it's a big change now to introduce the child voice, try to make those items be in child-friendly terms, and now to test them out. But ultimately, we have to bring that voice into care in a way that we as clinicians would trust and would actually change our care based on the child voice. So we have some work, I think, to do to say what would help us trust the child voice enough that we would change what we do. We might even listen to that voice more than our own voice, or we might learn strategies that would combine voices, the parent voice, the child voice, and the clinician voice. So we have more work coming after developing the child-friendly terms and testing them.
And I wonder if you could expand a little bit on the palliative care special interest group that you have developed, and between you and Maureen Lyon, you have about 6 NIH grants that focus on different aspects of palliative care, and I think the audience might want to have a kind of an overview of the areas that those cover.
Thank you so much, Mark. You are all warmly invited to join Maureen and me and the members of the Pediatric Palliative and End-of-Life Special Interest Group that meets the 3rd Friday of every month from 1 to 2:30 on the 6th floor of the main tower. And in that group, we are purposely combining clinicians and researchers, basic scientists, clinical scientists, so that together we can generate an impact with knowledge on direct clinical practice, research ideas, advocacy and policy. I know Kate is still here, but she's helping us to lead that effort. And education, we're developing curricula, we're developing interventions that we believe could have full promise of helping children and their parents who are dealing with symptoms or who are considering and contributing to end-of-life decision-making. And we have maybe 26 of us now in this SIG. We're all disciplines, and we are from across the country. We have members from Michigan, Ohio, Tennessee, who call in every month. And Dr. Batchel's correct, we have developed grants together, we have published together, and we've done workshops together. A huge hit workshop recently offered by Dr. Lyon, Dr. October, and Dr. Watson, and 2 others in our group, so that we can change our thinking. That's how we have to use our facts and figures, isn't it, to really examine our own thinking. And that requires a huge amount of insight. I'm going to link the grant success that Dr. Lyon and others in the group, including Dr. LaFawn, have had right back to Dr. Scheidt. Dr. Scheidt created a lot of what he does to particularly bolster the efforts of young and new faculty. Like Dr. Lyon and I would say, wow, he's terrific with leaf fossils and takes all of our grants and makes them better. And so I have such praise for how he reaches out to all of us. And I want to share with you the importance of this, because when he works with me, he'll say to me, maybe this idea is important. So it's so good for me to then say to myself, okay, now I've got to go back and make that language clear, because I know it's important, but if it doesn't come across to Dr. Scheidt, it's not going to come across to anyone about how important the idea is. So the way that he encourages us, that keeps us trying, is masterful.
Thank you, Pam. A few comments. First, Ann, thank you so much for a very valuable and informative overview of and presentation of the status of palliative care and pain research. My training years were in the late 60s and practiced through the 90s, and we always thought we knew what we were doing, even then, and I'm stunned to see how late the recognition of and the research in this area has come, and how much more there is to do. I was particularly reminded about that this past summer when my wife fell and broke her hip at the bottom of the Grand Canyon and had to be medevaced out, and spent 2 weeks at a university-based research center, and how difficult and inadequate the pain management was. I was like Shirley MacLaine in this movie. And even in a university-based center like that, there's still so much more to do. I'm happy to report that she's playing golf with her lady friends this morning, so she's doing fine. I have a question about your presentation. The brackets that you showed for the clustering of symptoms, and how they came together, the further out to the right you went. What did you mean by the further out to the right? What was on the x-axis that brought them together?
Okay, that's the statistical sort of mumbo-jumbo that Charlie tried to explain to me.
Okay, so that's a path analysis kind of thing?
Yes, it was basically a path analysis, and what he kept saying to me is, he said, what we kept bringing into the statistical analyses was the patient's report of functional impairments. That was a very important concept that he was putting across to me. And he said, so that the further out you went to the right, it was not about them being proxies for each other, but how they co-occur.
Okay, or like a factor analysis.
Yes,
yeah,
yes,
right.
Yes, a factor analysis.
Yeah, that would be what that was about.
Yeah, so my statistics, not so good.
No, that's fine. So anyway, congratulations on the work you're doing, and moving
we're supporting.
Moving this well. From your perspective, having been in that role at the NIH. You know, you serve as a coach to those you're working with.
And a cheerleader.
And a cheerleader. But more importantly, the challenge for you is how to move the field forward and how to identify the questions that need to be addressed using all the mechanisms available to you at the NIH. And that's very important.
I so agree with you, and I'm going to build on Ann's important comments from Dr. Cleveland's work about cluster analysis, and Chris also working with cluster analysis. And as we've learned more about symptom science, we keep applying to our data different analytic approaches because we don't think we've quite got that analysis yet. And so cluster analysis brings a lot of data reports, groups them by similarity. We have a colleague here at Children's National, Dr. Jishuan Wang, who is taking this in a different approach and takes it by personhood. And this is really an exciting analysis. So he's doing latent group analysis, latent trajectory analysis. And what it's teaching us is that it's not so simple as the group scores say that at time 1, the average suffering is this. And in group 2, the average suffering is this. He's teaching us by his analytic approaches that there are some children who will always be high sufferers. And so they start out at a critical point in treatment and they have horrible scores, high fatigue, high pain, high depression. And across measurement points, they stay high. Then there's a group that's low. And these children start out, and no matter what's happening, they really fare very well across time. And then there's 2 middle groups. And they start out looking very good, and they get progressively worse. So if we, as clinicians on the front end, could identify which child is likely to be the high sufferer, we're going to dedicate a lot more resources to preventing and lowering that suffering. And that's what these advanced statistical analyses are teaching us and prompting us to ask new and different research questions. And that's the beauty of building on the work that's been done with cluster analysis by 2 great previous scientists.
So I have a question about your palliative care program here. One of the challenges that we face in the adult setting is in those institutions where we have palliative care and they bring in a palliative care specialist into the scene, patients and their families immediately say, oh, so this is the end, doc, huh? This is it. There's no more. And in fact, Eduardo Barrera, who is an oncologist and has really moved into the field of palliative care, symptom management, et cetera, at MD Anderson. In fact, he started the palliative care service at MD Anderson, and he's renamed it. He's renamed it to the supportive care services because he said it's about intervening early. And he said as much as we want to say palliative care, people have harbored this. It's the end of the road, doc, isn't it? This is it. So I'd like to know how this is playing out in the pediatric field.
So I'd like to respond to that a little bit, and I don't in any way mean to say I'm speaking for every pediatric institution in the country. I will only speak for our institution. We encounter many of those same barriers, the wording, and for a while we did not even have the word palliative in our name of our team. We were just the PANDA care team, and PANDA actually stood for something, Pediatric Advanced Needs and Assessment Team. However, we purposely decided to put it back in because words only have power if you give them power. And so a lot of it is in the way that we explain palliative care to patients and families. And we explain it as a quality of life support. We're here to make every day the best it can be, regardless of what the circumstances are, for as long as it can be. And it's a focus on the living, not on the dying. I do want to give a plug for the National Institute of Nursing Research palliative care brochure, which came out of the Conversations Matter project. It's online. We have it. We're happy to send it to you. It is unbiased. It does not reflect any institution, and it explains palliative care in this very basic way of let's make every day count, let's make every day the best it can be. And when we introduce it that way, it's almost universally accepted, because who doesn't want to have the best day they can possibly have? So I think we need to get away from giving the word power, because, you know, do you want the palliative care team to come? You know, it sends a different message than, hey, here's this team that's going to help make things a little bit better. So thank you.
And thank you. Oh, I'm so sorry. Was there a question?
Debbie, this is a question to you, but it's just an enlightening from the standpoint of symptom management. Would you say that in our current clinical practice that nurses who are working with patients that are either palliative care or on chemotherapy are using the language of symptom clusters? Because if they're known clusters in terms of known that they're together, has it actually integrated into practice where these clusters have known interventions that will help reduce the burden of the cluster?
I don't think that we're doing it on a routine basis in a prospective way. We often link symptoms just because in practice we see them occurring that way, but I would agree with you that I don't think we're purposely addressing symptom assessment and management like that. The one thing I do think that the palliative care team and many of my former colleagues in oncology, I'm a recovering neuro-oncology nurse practitioner. I'm never going to get out of my blood. Anyway, one of the things that we always try to ask is, what is the symptom that is most distressing to you? Because for one, and it gets back to a comment Dr. Hines made about the high sufferers and the low sufferers. For one patient, pain may be the worst thing for them, and another patient, it's the fatigue that is the symptom of most concern. So it's not always about looking at the cluster, but looking for the patient and the family. What's the symptom of most distress, and what does that mean to them in the context of the disease? I think that one major finding from my initial work in bone marrow transplant is that families just wanted us to sit down and bear witness to their journey. They just wanted to talk about these symptoms and what they meant. It wasn't always what drug are you going to, prescribe, what intervention are you going to do, but let me tell my story. Let me tell you what this means to me and what I am worried about. And we found in our work that so even those that were high sufferers, when we sat down and just listened, they didn't have an increase in their symptom distress. We actually were able to decrease it, or it stayed the same. Small sample. So I have to say that. But I think it is about listening and finding out what the meaning is. But you make a very good point.
Eileen, I think that I would interpret your question that the clusters, I think, form important research questions that need to be addressed to understand the mechanisms of the clusters and how that can lead to more effective interventions.
I really appreciated your note about pain doesn't occur in isolation, but the next slide was not what I expected, but follows up on what Debbie was just talking about of sitting with people and bearing witness, because there is research that shows that people can bear pain and tolerate it if they have the touch of the hand of a loved one. And of course, nursing came out of this whole field of tender loving care and touching the patient, in contrast to psychology, where we're not supposed to touch the patient, and they talk about boundaries. But I think perhaps there can be more research also in the area of patients who are isolated, even sometimes children, particularly with stigmatized diseases like HIV, where it can be very hard for somebody to feel supported, and that's a place of real need in terms, I think, of future research, particularly unsupported young people who don't have somebody to touch them, or for many people, or religious faith or whatever that helps to get them through a community that helps them get them through these difficult times. So.
Beautiful.
The art.
Yes.
The art.
Mm-hmm.
This conversation reminds me of a very
simple but elegant study conducted by an advanced practice nurse, I believe in Iowa many years ago, and she was looking at ways to help her patients with cancer undergo their treatment procedures. And simply hand-holding was a significantly effective intervention for coping with the pain that they had. And she also asked, whose hand do you need to hold? And number one hand was their parent, and the second hand was their nurse. And so I think that this power about the art and thinking, beyond drugs and those things, that our presence, our touch really can make a difference, and we need to continue to study that as well.
Is it on? Okay. So from a nursing student perspective, I've done clinicals in pediatric settings where kids have a lot of pain, and I've noticed there's kind of like an apathy on like the provider or nurse, whoever the healthcare professional is, like dealing with the pain. And I think there's like they're trying to reconcile like a patient being in a lot of pain and trying not to like over-medicate them or have them like rely on that pain medication. And so I just wonder, what's the best way to approach a patient who is in a lot of pain but is just in chronic pain, and you don't want to like over-medicate them and still have that passion in treating them?
I can take that from the adult world. One of the things that we've learned, Pam mentioned about my being on this trans-NIH, a lot of these working groups. Amongst them is the pain, is trans-NIH pain. And so I come with the cancer pain. But the chronic pain that I've come to learn from my colleagues at NIH is, and being active in the American Pain Society, I don't think we put enough emphasis on the multidisciplinary approach for managing chronic pain. And I think you give a very good example of what you're seeing. And I think in using our discipline of nursing is, I think sometimes we feel it's all on us to try to manage this pain. And I think we've got to open our eyes to bringing in more disciplines and helping patients manage. The big thing I've learned in the chronic pain is that there's a lot of cognitive behavioral approaches that are really efficacious, and we're not using them enough. We don't know enough about them. I really believe that is incredibly important, and I don't think we do that enough in the clinical or the outpatient setting for our chronic pain patients. And, bringing it even into cancer, one of the interesting things is last year the NIH had a consensus conference on the role of opioids in chronic pain. And the reason for that is, I'm sure some of you are aware of what's going on in the literature and in the media of this abuse, this huge abuse that's going on. And a lot of it started with the cancer pain group with our, we've got to give more opioids. And that has, for lack of a better word, sort of backfired on us. But the interesting thing is when I was on this planning committee for the opioid, I went because there's still this perception out there, if you are diagnosed with metastatic cancer pain, you have maybe 3 months, 4 months. So that's not an issue, opioid use in chronic pain. That is the furthest from the truth. First of all, our populations with metastatic disease are living a very long time with chronic pain. It is a very different phenomenon than what Charlie Cleveland saw in 1983. The second thing is, and that's why I brought up chemotherapy-induced peripheral neuropathy, this is a huge issue for our survivors who are free of disease and have to live with this chronic pain. And my hypothesis is that our survivors are equally at risk for poor management as well as abuse as the rest of the non-cancer population is. And we really need to bring in more disciplines to manage this pain. So the short answer is multidisciplinary.
So, Anne, thank you so much for a stunning beginning of the day. I'm so happy about that. Dr. Scheid, Dr. Batshaw, Dr. LaFawn, and to every one of you, thank you for a great conversation. This is exactly what this day of celebration is about, and I thank you for this fantastic beginning.
We will conclude the opening keynote at this moment in time and take just a few moments to get ready for the presentation that follows. Thank you all.